In this video, I will demonstrate how we create proximal radial-basilic vein transposition fistula using a modified microsurgery technique. In this video, we apply the LigaSure device for surgical dissection, reducing the number of suture ligation while reducing the time for the surgery. I have no financial interest or relationship to disclose. Our patient is a 72-year-old man with diabetes and hypertension. He has a failing radial-cephalic fistula draining via collaterals to the basilic vein that we need to close. Planning is a major step prior to any access surgery using duplex scan. Since the superficial veins are exhausted, the only options for native fistula are transposition of the basilic vein. These are the patient's arm drawing of the findings using duplex mapping. We chose the left arm that was suitable for proximal radial-basilic fistula rather than the right arm that was suitable for brachial-basilic vein transposition only. We do all vascular access surgery using regional anesthesia. In this case, we applied supraclavicular, infraclavicular, and PEX2 blocks. Then we remap the blood vessels to assure the surgical plan and mark the skin incisions with ultrasound guidance. We shave and scrub the arm with soap and then with alkoxidine. We use a sterile sleeve to cover the forearm, and then we isolate the entire arm with sterile cover. Then we mark the course of the vein on the skin for the surgical incisions and dissection. We start with closure of the failing radial-cephalic fistula. We gently dissect the vein up to the anastomosis to the radial artery. The vein is elevated using vessel loop. We continue with the dissection until the anastomosis is fully exposed. We close the fistula at the anastomosis with neonatal clamp and the distal vein with Kelly clamp. We divide the vein and suture it in 2 layers with 5-0 Porlin. The stump of the vein is ligated with vicryl suture. We use Surgicel for hemostasis, and then the wound is carefully closed in 2 layers. Now that we have closed the failing fistula, we can go ahead with the basilic vein transposition. We use skip incision to dissect the vein rather than using a long single incision. We start with a longitudinal incision at the distal basilic vein below the elbow level. The basilic vein is gently dissected and the anterior wall is marked in order to preserve its position during the tunneling. The vein is elevated by vessel loop. Now that we have the LigaSure that permanently fuse vessels up to 7 mm in diameter and tissue bundles without dissection or isolation, the average seal cycle is 2 to 4 seconds and the seals withstand 3 times normal systolic blood pressure. The use of LigaSure reduces blood loss compared to sutures and clips, reduce lymphatic collection, reduce procedure time, and reduce patient length of stay compared to sutures. At every step, whenever possible, the anterior wall is marked and the vein elevated with vessel loop. The vein is dissected as far as possible proximally and distally via each incision. We now move forward to the proximal incision just above the elbow. The vein is carefully dissected using extensively the LigaSure, including cutting the fascia and all the tissue around the vein while preserving the medial cutaneous nerves. Dissecting the tissue around the basilic vein with the LigaSure fuses the blood and lymphatic vessels, preventing postoperative lymphatic collections or hematomas. From time to time we need to ligate the large branches with Vicryl and then cut it with the LigaSure. You can also use the LigaSure to fuse a bleeding vessel better than diathermy. While probing the subcutaneous plane with the finger, the next incision is marked in the skin. Now we move to the proximal incision. You can appreciate how fast and smooth is the dissection and how bloodless it is. Now we have reached the confluence of the basilic vein with the brachial vein. You can appreciate the branches that draining to the deep brachial vein. Ligation of the branches may lead to thrombosis of the brachial vein and may cause swelling of the arm. Since we have sufficient vein length for cannulation, we do not need to take this risk and we can stop the dissection here. We go ahead with the arterial inflow from the mid-forearm radial artery. The LigaSure play a major role in the dissection here. The radial artery at that level is below the muscle and we cut it and the fascia with the LigaSure. The anterior wall of the radial artery is exposed and marked. We use a vessel loop as a signpost for the artery location. We create a subcutaneous tunnel with a gore tunneler up to the proximal incision in a straight as possible line. We divide the distal vein with the LigaSure. Using a DeBakey forceps, the vein is carefully pulled but not pushed through the incisions while maintaining its correct orientation and avoiding vein twisting. We place the vein on a wet pad, flush it with heparinized saline, then we close the proximal vein with a soft clamp and then the vein is gently inflated with heparinized saline. We fuse a small leaking branch with the LigaSure device. The vein is tunneled through the tunneler using a urological flexible grasper. The vein is closed with a soft bulldog clamp and then placed and fixed with adhesive strip. 40 mg of heparin is used for systemic heparinization, and 3 minutes later we exsanguinate the blood with S-mark bandage, and then the tourniquet is turned on and the S-mark bandage removed. The vein is shortened to fit the anastomosis to the proximal radial artery, and the bulldog clamp is removed. The artery is inside longitudinally with an Alcon knife, and then with cazzo viejo scissors to about 4 mm length. A 2 mm coronary shunt inserted to the radial artery, preventing blood leak at the incision as much as possible. An end-to-side anastomosis is performed with a continuous 7/0 Poland suture, starting at the heel with the lateral side of the artery, then we continue with the medial side of the artery. The shunt is removed and the sutures are gently tied, avoiding shrinking of the suture lines. The tourniquet is turned off with immediate blood flow via the created fistula without leak from the suture line. A nice thrill is felt. We cut the fascia and muscle with a LigaSure device, reducing the pressure on the vein. We use Surgicel for hemostasis, and then the wound is closed in 2 layers with 4/0 Vicryl and then 5/0 Dermalon. The mid-incisions are closed with absorbable Stratafix sutures in 2 layers. The proximal incision is also sutured in 2 layers with Vicryl and then Dermalon, exactly like the distal incision. This is how the surgery looked like at the end of the operation. A visible skin bridge is seen on the skin caused by the tunneled transposed vein. We cover the wounds with dermacombine ointment and then Cosmopore dressing. 3 hours postoperative, the patient is discharged from the hospital in a good condition. 12 days postoperatively, at suture removal, the surgery looked good without collection of blood or lymphatic fluid due to the LigaSure device. You can clearly see the well-developed vein. 1 month later, the vein diameter is 5 to 7 mm and the flow about 1100 ml per minute, and the fistula is ready for cannulation. We attach a drawing of the fistula with marking the cannulation site, one of the forearm and the second in the upper arm. Nevertheless, the patient is stable and doesn't need hemodialysis yet. 4 months postoperative, the arm looks good, the vein is well developed and the flow is 1 liter per minute. The patient didn't start hemodialysis, but the access is ready when needed. You can appreciate the duplex screening of the fistula. There is a reverse flow in the distal radial artery and rich flow in the ulnar artery that supplies the fistula as well. In the mid vein, you can see a mild stenosis in the vein due to a thickened valve that we may need to angioplasty in the future. Thank you for watching this video.